I
Yeah.
apologize. My neighbor just started mowing the lawn. Do you hear that?
I don't hear it, but it always happens to me.
Hello, Dr. Heidi Kohltfarber. How are you?
Good. How are you?
Good. Hey, this is, it's coffee and cone beam, but
Yeah.
this is water today because I've already had 2 cups of coffee. So I shouldn't have any more. Um, and
Well, I have tea. So on a cute little mug that my daughter got me for
at least you
Christmas.
don't have ugly children. That's great. That's great.
It really was supposed to be a super sweet one, but she was mortified when that showed up instead. You know how Amazon can kind of switch stuff on you.
It's a thought. It's a
It's a
thought.
thought. It was so cute. So I
Good.
had to keep it.
And you have snacks with you?
I do. I do. I'm definitely British. I got Fox's jam and creams.
Oh,
So
nice.
99 pence right there.
Is that a British thing? I didn't know
Yeah.
that. Okay.
Yeah, I have them shipped over every couple of months. I get my stack.
Wow. That it's important to you.
It is important. Yes,
Good.
exactly.
So,
So,
Dr. Heidi Kohltfarber, if you don't mind, I'm going to give you a brief introduction. If you
sure.
could add to it, because you're doing a couple of new things that I want to know about, and then we'll look at a scan together. Is that good with you?
Yeah,
All right.
absolutely.
So
Super fun.
for an introduction, I want to tell everybody Dr. Heidi Bridget
Yeah.
Kohltfarber, that's all right if I share that, is
Of
the
course.
owner and managing oral and maxillofacial radiologist for Dental Radiology. In addition, she is that the whole title? Dental
No,
Radiology
it's dental
Diagnostics
radiology diagnostics. Yeah.
.com.
Yes.
Okay. In
Yeah.
addition, she is an adjunct professor in the Department of Diagnostic Sciences at the University of North Carolina at Chapel Hill and an assistant clinical professor in the Department of General Diagnostic Radiology at Loma Linda University School of Medicine. She was voted onto the Executive Council of the American Academy of Oral and Maxillofacial Radiology as a counselor of communications in 2022.
Yeah.
That's a lot.
Yeah.
You've been busy. Also, she is an alumni of, oops, she is the alumni of Western Christian High School.
Yes.
Go
Woo!
Lancers.
Go Lancers!
So Dr. Heidi and I went to the same high school. I'm older than she is, just to let you know. So we didn't go at the same time, but we went to the same high school. So it's cool to just bring that up every once in a while. She studied harder than I did. I'll just tell you. That's um, right now. She's got a couple websites. Again, I mentioned Dental Radiology Diagnostics. .com, and that is a great service for reading CBCTs, and you provide reports and some services there, as well as your new project. I think it's a new project, and could you tell us about that website?
Yeah, so this is drdxdocs.com, and this is our new radiology educational website. And so it was put together with one of my mentors at UNC Chapel Hill, Dr. Don Tyndall, who's absolutely an amazing instructor. And we basically put together, an entry level CBCT course. I think it gives about 6 CEs, about 6 to 7. I'm trying to remember exactly right now, but it's a full day course that's like a basic CBCT course, but we've broken it all up into micro learning.
Mm.
And we figure, you probably don't have a whole day to sit and review all of this. So it's all been broken up into, like 10, 20-minute segments at most, so that if you have a spot in the middle of the day, maybe a patient didn't show, maybe you just want to get a little bit of extra radiology education, you can watch one of these videos, and when you complete, the 1 hour course, then you get a CE credit.
Oh, that's
So
great.
it's kind of cool. So you can go as you'd like with it.
Very cool. I
Yeah.
apologize. My neighbor just started mowing the lawn. Do you hear that?
I don't hear it. That always happens to me.
This is real.
I can't guarantee I'm not gonna have something like that.
I'm gonna let it go. I'm thinking everybody understands what our world is like today. So this is real life. My neighbor just happened to start mowing.
That's awesome.
But we'll keep going with this. So thank you again for joining me on this. What I would like to do is just show you a scan and give you an overview of our software. And what I'm curious about is how you go about looking at a scan for a report, so people will know if they go to your site for services what to expect as well in your process. Is that okay?
Yeah,
Okay.
absolutely.
So let me go ahead and share my screen here. And let's see here. We'll minimize this. Okay. This is called Vision X. It's our software. Layout looks very familiar, right? You get the panoramic image, and you have the 3D volume here, axial view here, cross-section view here. So that's standard. What we do different is that panoramic curve is automatically detected for you and drawn out for you. It's all adjusted for you, I should say. And the nerve is already mapped out using AI, but we don't tell clinicians, we don't tell people that that is 100% accurate. So we always want to give a starting point, but we want the clinician to review it. Let me show you how that works real quick.
You can adjust that then.
Yeah, let me
Is that right?
show you. Yeah, you could adjust it. So first off, the panoramic curve, instead of drawing it or moving that curve, what we could do is click on this. We call it clear pan. What it does goes to the volume and creates a panel for you. And you could adjust the width here if you'd like. Okay. And then the nerve is mapped using AI. It goes through the full volume, and then it asks you to check it and verify it. And of course, we do that in the cross-sectional views here, and we could look at that as well. So it gives you a good starting point. That's done during reconstruction, by the way. It's not something you have to click on. It's just, this is the first screen you would look at.
Awesome.
In these views here, we have the transversal slicing views. So these are 3 views. This is the panorama view where we start. This is the transversal slicing acquisition view, and this is the MPR view. So these are the 3 views. And navigation is just like you're used to in the axial, coronal, sagittal views, right? Those are all the same. And what I would like to do, if you're comfortable with it, I'll just give you full control and you can move it around. Would you like to do that, or you want to just tell me how you want to navigate? What would you like to do?
No, yeah, let's go for it. Let's play with it.
Okay, so I'm giving you full control right now. Can you move?
Let's hope it's gonna work.
Is it? It's real life. There you go. Okay, so if you don't mind, talk me through this. What are you looking at? What's going on in your head when you're looking at a scan for the first time?
So the first thing that I'm gonna look at, I want to make sure there's no motion. So that's super important. So let's go ahead. We're going to move right to the midline right here.
Okay.
And we're going to check our cortical borders. And if you had the cervical spine, we would check that as well. So usually if you go right to the sagittal sections and you look right in the midline.
Okay.
If you have double cortical borders, then you know you'd have motion artifacts. Or if you see multiple streaks in your axial sections or your coronal sections, then we know we most likely have motion artifacts, and the sagittal typically confirms that. So this is a great scan. We don't have any motion.
Okay.
Now, can we reorient the patient? Is that possible on this one? I
Yeah,
mean, this
how
patient's oriented perfectly, but typically, if the patient is not oriented in a symmetrical fashion, we'll go ahead and reorient that patient also. So
so
those are look
when
at.
you say that we could actually click on the view and rotate it. Is that what you're asking about?
Yeah,
Yeah,
can
let
you
me
click on?
let me do that. If you go here in the corner, you
Oh, I
could
see.
rotate it like this.
Ah, there you go. Perfect. Oh, maybe I might. Okay, so it's you said, can I bring down the sagittal, or is it just the axial that rotates?
They all rotate
Okay.
like this.
Oh, I see. So you
And
come
then the
down.
sagittal over here,
Yeah, so I would bring him down just a little bit.
chin down like that.
Chin down just a little bit.
More.
Yeah.
Okay.
Perfect. Right
You,
there. Right
okay.
there's perfect.
Okay. Let me give you.
Okay. So that kind of makes it a little bit wonky here, but you're gonna have like some really nice symmetry, and then when you go to do your panoramic reconstruction as well, then you have that nice smile line. So those are the things that I typically look at
Okay.
when I'm just setting up my case.
Okay.
The other thing I'm going to do is I typically do 3 passes in my axial, my coronal, and my sagittal sections. Now, this patient, and probably the way that it's reconstructed and set up, we don't have a cervical spine here. Is
That's
that
right.
probably on purpose?
That's unique to our machine. It is
Okay.
it is just it's shaped like the mandible. So
Okay.
it doesn't have the airway. We really our sweet spots where we sell this machine to is really general
Mm-hmm.
practices that do implantology is really the main market, and endo, but not really for airway or TMD. That's
Yeah, that's fine. So this looks like it would be a workhorse, especially for implants and endo.
yeah.
So that's awesome.
Okay.
So with that, you're not going to see the cervical spine. So usually that's one of my passes that I'll do. I probably still am going to do 3 passes. I typically try to keep everything exactly the same. I'm very systematic in how I review it, so I make sure that we don't miss anything.
Okay.
So I don't take any shortcuts as far as that goes, even when we have the smaller volumes. But I typically start up at the very top in the axial sections. So I'm going to start up here, and for this one, the most superior aspect is going to be the maxillary sinuses. And let me see, we're at what the midpoint inferior aspect of the sinus. Yeah, okay. So that's going to be our top where we're going to start.
Okay.
So things that I'm looking at as I'm coming down through, I'm going to look at my sinuses, and typically I go through the anterior aspect, come up through the airway, and I go down through the cervical spine. That tends to be kind of my MO there for my systematic pattern of review in the axial.
Okay.
But as I come down, I'm looking again, those maxillary sinuses. Of course, we can see we have mucosal thickening within the sinuses. We definitely would want to rule out an odontogenic source for that.
Mm-hmm.
But one of the things we see right off the bat is our cortical borders of the sinuses are nice and thin and intact.
Okay.
And so using symmetry, having, making sure that everything is rotated perfectly allows us to use symmetry. And so you can compare one side to another. Even if you don't quite remember all of your anatomy, you could go ahead and compare one side to another. So if it's nice and thin and intact, we know that whatever's going on is most likely an acute or allergic situation. Now, again, I think we might have a odontogenic source here for this one. So if you ever have any questions, you can put your crosshairs and look at it in all 3 planes. But as I'm coming down, I'm also going to look at my nasal septum. I want to make sure I don't have a deviated nasal septum as I come down. And coming into our maxillary dentition, we can definitely see we've got something going on. So I go ahead and put my crosshairs on that. Again, I'll look at it in all 3 planes. I'm assuming, can we enlarge these?
Yep.
Cool. All right, so we can look at that a little bit more locally, looking at our sagittal sections, and so we can see, definitely we've got something going on there. So go ahead and just jot that down. And how do we make it smaller again?
That first icon on the top corner there. You had it. You're on the right side.
All right. Okay. This guy.
Go to the left. There you
this
go.
guy.
Yeah.
All right. Cool. Super easy software.
Yep.
All right. I don't know my crosshairs one. Anyway, so all right. So we've checked out the maxilla. That looks, pretty good. We know we have an issue on tooth number 14. Coming down through, and I'm looking at cortical borders, looking at my incisive canal. Make sure that typically look at my root canals as well. Make sure we don't have any sort of internal root resorption or maybe opacification of the canal, letting us know that there may have been a history of trauma or anything like that. And we see a couple things going on over here. We do have beam hardening artifacts with our CBCT.
Mm-hmm. Could you explain what that is?
Yeah, so what happens is that the ray, as it's going around, it will hit something that is metallic, and it will completely absorb all of those X-ray photons.
Okay.
And it leaves behind it kind of this like a black appearance behind it.
Mm-hmm.
And so what happens is that the algorithms are expecting to see something, and they don't have anything there. And so it makes it really dark there.
Got it.
Sometimes we'll see white streaks with that.
Mm-hmm.
And that's because it's an error in the algorithm. It's expecting to see something that it's not seeing. And so we have this kind of streak artifacts that can go with it. So because of that, because we know we're going to have this artifact around all of our metallic restorations, we tend not to diagnose caries off of CBCT. My CBCT is amazing at everything else, but caries, I would say, very conditional.
Mm-hmm. Mm-hmm.
However, we might mention that it looks like we have some things going on, and you need to take some intraoral bite wings to accompany the CBCT to help rule out caries.
Okay.
Now, if the patient has no metallic restorations, we might go ahead and say, it looks like we have some coronal loss of tooth structure that may be suggestive of caries, but we don't come straight out and say they're caries.
Okay.
And we're kind of careful in our wording there just because we know that this can happen. All right, so once I've gone through my maxilla, I tend to jog up just a little bit, and I want to grab my temporomandibular joints, or the most superior aspect of my ascending ramus.
Yeah, so this volume doesn't have, it doesn't cover that. It goes 8.5 vertical.
I would assume that if you have a small volume, like a smaller patient, you'll see them. Is that right?
That's right.
Yeah, but with a larger, you probably won't. But anyway, I go to the most superior because I want to start at the most superior aspect to that ramus and go all the way down through.
Okay.
And again, I'm looking at those cortical borders, wanting to make sure that everything is smooth and intact. So when I'm looking at things in my axial as well as my coronal, I am looking more globally in appearance. And when I come to my sagittals, when I'm looking more local.
Okay.
So we definitely want to review the whole CBCT. So I always go through all of the global evaluation first. So I'm coming down through, again, you can easily see we can compare symmetry. Obviously, you're picking up that mandibular canal so nicely, and that's really cool that automatically does that. That's fantastic. Makes it so easy. You can see exactly where that is situated in relationship to those third molars. And again, nice, smooth, intact cortical borders. One of the things with CBCT is we can't differentiate the soft tissues.
Mm-hmm.
So we're really keen on looking at those cortical borders because we know if the cortical borders are missing, it could tell us that there's some sort of a pathology within the soft tissues that's causing a erosion of the bone. So those are kind of things that we look for.
Okay.
Now in this particular case, we can obviously see that we do have some thinning of the buccocortical border. in this region, the anterior maxilla, and let's see about the lingual. The lingual cortical border, maybe just a hair thinned, but it's mainly the buccal cortical border.
Okay.
And of course, we can always put our crosshairs on it if we are concerned about. Let me grab those. There we go. And we saw this before, that we have a nice little lesion right here. So I'll go ahead and peg that. I'm going to come back at some point. I would measure that, look at all of the radiographic features with that. But for now, I'm going to keep going on down. There we go. All the way down through. And then I'll come up looking at my airway space. And of course, this looks like these are our little hyoid bones right here, right there. You can see that very nicely. We just got a touch of them. We can see the epiglottis right there. So we know we're about the C3, C4 level.
Okay.
So you can kind of base that off of the fact that we see the hyoid bone. Even if you don't see your cervical spine, you know what level you're at.
Okay.
And this tends to be the level that we see calcified carotid atheromas at. So I'm going to look posterior and lateral to the airway space that typically are going to be, out in this area, and they're going to have an arcuate appearance. These little calcifications will, because they're rimming the artery.
Okay.
But we don't see that with this case at all. So this looks great. So I'm going to go all the way up, there you go, through the airway space, making sure that everything looks pretty nice. All right, and once I've reached my top, I can just do a quick review, just kind of looking at that most posterior aspects, even though I don't have that cervical spine. And all the way down. Just making sure there's nothing going on in the soft tissues on either side.
Got it.
Okay. All right, so that's my look in my axial sections. And for my coronal sections, let's see if I can move this anteriorly. There we go. So I usually start at the anterior aspect of the patient with my coronal sections, and I divide it up into thirds as well. So when I go from front to back, I'm going to look at the most superior aspect, and typically I'm going to look at my sinuses. If we have it, we'll look at the orbits, the nasal fossa, that sort of thing. So I'm just looking at my more superior structures. I'm not even looking at the maxillary dentition at this point. I'm just going to make sure that my cortical borders are nicely intact. Of course, we could see our nice incisive canal right there. Moving back, I want to make sure cortical borders, we already talked about tooth number 14. I'm making sure the palate is nice and intact. Lateral aspect of the nasal fossa, maxillary sinuses. And all the way back. Oh, cute little third molars, but making sure everything looks good. And we have our medial and lateral pterygoid plates. You can see that right here very nicely, medial and lateral, and all the way back. All right, then I'm going to come forward, and at this point, if it was a larger field of view, I'd pick up on my cervical spine. At this point, since we don't have that, I'm going to look for my mandible, and I'm going to go down through the mandible. So just coming anteriorly, and I'm looking again, making sure that our cortical borders are nice and smooth and intact. Everything looks good. Check out the teeth a little bit as we go along here, but definitely making sure these cortical borders are nice and intact. And all the way to the anterior mandible, where we know we have a little situation there. And then I'm going to do one pass back, just looking at my maxillary dentition, and making sure that everything looks pretty good from there. Let's see. Oh. Definitely have an issue with this tooth right here as well. See a little periapical lesion there, and all the way back. And so at that point, I'm done with my coronal sections, and I'm going to pick up going through my sagittal. I always pull the crosshairs over to the right-hand side.
Okay.
And then typically with this, I'm going to go ahead and, with any of these, I usually enlarge this, but definitely want to take a peek. Let's see if we can make it go down through. Actually, okay.
You could also drag in between the windows to make one window larger.
Can I?
Yeah.
This is awesome. Okay, so I did that one. Can I drag up here?
Yeah, you sure can.
Oh, so okay. Okay, I'm gonna have to try to make myself symmetrical here. OCD kicking in.
Yeah, I could see that.
All right. Yeah, yeah. All right. So that's really cool because then you can enlarge this. You can be reviewing it while you're, you can see exactly where you're at. All right. So let's come down through here. And I'm looking at my periodontal ligament spaces. This is great. The sagittal is great for looking at your periodontal ligament spaces. You see it really nicely and see what's going on with each of the teeth. Obviously, our issue here may be interesting. Yeah, you can see that root apex right there as well. So definitely wanting to see if we have any type of root resorption with that particular lesion. That's really nice. And all the way to the left-hand side. All right, perfect. I can barely catch those little condyles, just a little bit, but all right. And then I'm going to go from the left side to the right side, looking at the maxillary dentition. So you can see, the relationship of that third molar to the distal aspect of number 15. Want to make sure there's no root resorption. Obviously, we can see 14. We have a nice periapical lesion with most likely an associated mucositis. And see all the way around. But definitely making sure that everything looks good. I'll come back to that. Okay. And yeah, our premolar looks like we've got a little apical lesion going on there as well. So our mucositis on this side is kind of interesting. So we do have, I would say we do have mucosal thickening that may not be odontogenic in origin, but we do have some that may be odontogenic in origin. So what I typically will say is that we have an acute or allergic rhinosinusitis in conjunction with an odontogenic source. Because you can see that it's starting to kind of crawl up the sides of the sinus.
Okay.
So if it's crawling up the sides of the sinus, most likely it's not just odontogenic in origin.
Okay.
They're kind of both. But yeah, so that's what I would say for that. And again, over to that right hand side of the maxilla. And then I typically do one swing through just looking at the midline structures. So I want to make sure that my incisive canal looks pretty good, nice straight canal. We don't have anything in here that looks like we have a cystic process. When I'm looking at it in the larger views, which I don't know if you have the larger views as well, but we would look at cervical spine, sella turcica, and that sort of thing. Okay. So making sure those midline structures look good. And then we're done.
Wow. So yeah. For the report, you write all this out. Is that what's to be expected from a report?
I usually, anything that I've talked about, I'll go ahead and write out. Definitely we would come down and spend some time with this little lesion down here.
Would you measure that usually?
Yeah, I'm going to measure that. I want to discuss it. Hold on, let me see if I can move. Can I is it like an automatic to make them go back to normal?
Yeah, there's a, let me go ahead and do that. It's up on the, it's on the right side, and it's that skull with the arrow. Keep going to the right. There you go. Click on that. Reset. Or it should have reset. Oh, it's reset all the views.
Okay.
I think there's a, oops. Here, let me go back. Hey,
playing with it.
it's the beauty of having software you've never used before. I think it was this one.
Oh man, did I kill it. Okay.
I forgot which case it was. I don't know. Where was that?
One that has he has like a simple bone cyst or an odontogenic keratocyst.
I think this might be it. I'm not sure.
Yes, I think that is it.
Okay. Yes, we're back to normal.
Sorry. Okay, I can't go and play with buttons.
let me give you control. I'll give you control. Okay. I think you have.
She does not get control anymore. No control for you.
It's all yours right now. It looks like.
Okay. Yeah. So we come back down and look at this and make sure it's what it's doing with the teeth.
Okay.
Let me go ahead and I can pop this guy up in the corner. Does this one?
Yeah, let me do that.
Okay.
I just rotated that. I'm messing with the
Oh, man.
software altogether now. All right.
It's super easy software though.
It is. This makes it extremely large. Then when I click in here, I have this view here as well to maximize it for each
Okay.
window, and that's where the little square went.
That's what I was looking for.
Okay.
Okay. So yeah, so we can see it's well defined. So let me scroll it back.
What's well defined when you say that? The border of the
The
lesion?
border is well defined, but it's not necessarily corticated all the way around. So you see that lesion really well. So when it's well defined, it means that you have diseased tissue right next to the healthy tissue.
Okay.
And so it means it's something that the body has been able to wall off, which is a good thing. It tells us that it's slow growing. The body's had time to wall that off,
Mm-hmm.
and most likely it's a benign entity.
Okay.
Now, it's not necessarily corticated. Um, I would say that it has kind of a delicate margin, or we might say it's partially corticated. We like the word partial because then you're kind of hedging a little bit.
Yeah.
But you can kind of see that. So, what does that mean when it's corticated? That means that the body has walled that off, and you get like this white line around it. That
Okay.
means it's corticated, it's walled off. But this has actually a nice delicate margin to it. So not necessarily that thick cortical border we would see with a cyst. So it might tell us we have something else going on there. And then we want to look at the teeth. So of course we definitely have 26 and 27 that are in it, but we don't have any root resorption. So root resorption is important because it lets us know what kind of lesion it is again. So for instance, a ameloblastoma likes to cause root resorption, where something like a simple bone cyst or a odontogenic keratocyst will not.
Okay.
And this looks like, obviously we had our third molars. So this is a younger patient. My number one with a lesion such as this, so what did we say? It was well defined, partially corticated, but you have kind of those delicate margins to it. We do have thinning of that buccal cortical border, but it's intact. And it does look like it's scalloping a little bit. So you see some scalloping,
Mm-hmm.
kind of scallops
Mm-hmm.
up between the teeth. And the internal content, of course, it looks completely hypodense or radiolucent. With our CBCTs, we tend to talk about it in terms of density. And so we'd say it's hypodense inside. So my number one for this would be a simple bone cyst, which is also known as an idiopathic bone cavity. And those are essentially empty spaces. So when the surgeon comes in, he's going to know immediately what it is because it's going to be an empty space. And once he kind of scrapes on the bone and it starts bleeding, it's going to go ahead and fill in with bone and essentially heal it. So I always say if you're going to have a lesion, this is the one you want to have
Okay.
because it's not epithelial lined. It's really more of a pseudocyst. So when I went to school, they called it either a traumatic bone cyst or a simple bone cyst. And now they call it an idiopathic bone cavity. Early on, they thought it might have something to do with trauma, but there was no association with that. So they kind of dropped that.
Okay.
So really, idiopathic bone cavity. So that would be our number one in this particular age group. And our number two would be an odontogenic keratocyst. So those would be our differential, and we would go ahead and recommend a biopsy. But again, the surgeon's going to know immediately once he gets into that which one it is.
Okay.
But my bet for this age group would be our simple bone cyst or idiopathic bone cavity.
Okay.
Yeah. So we'd go ahead and write that up. We would write up any of the teeth that we saw, the periapical lesions. I do some custom sections with my software, and so especially with the teeth, I'll split out, your mesial buccal roots, your distal buccal, and your palatal roots, so you can see the lesions at the apices of each one and the relationship to the inferior aspect of the maxillary sinus.
Okay. Now, if
Yeah.
somebody turns in, first of all, how easy is it to get a DICOM to you? Is that the format you would want?
Yeah.
And how
Do
does
want
that work? If we go to your website, if a doctor goes to your website and they have a case in mind, what do they have to do to get a case to you?
So they do need to make an account with us, and then they can start submitting cases. There is an online referral form, so they can tell us exactly what it is they're looking at. Please tell us what you're looking at. So many times we get completely empty ones, and it's a fun Easter egg hunt, and we enjoy that too. We always look at everything. It's a complete pathological overread. But if you tell us what you're interested in, that helps us kind of be able to focus that particular report to what your concerns are. And then we'll still go ahead and put everything else down, but we can kind of tailor that a little bit better for you.
Okay.
And so they'll fill that out. And then they just kind of move along, hit the next button, and it goes to where you can import a DICOM. And you can either drag or drop it right onto the website, or you can use the browse feature and find wherever that folder is on your desktop. So you would want to, based on whatever software you have, you would want to go ahead and export that out somewhere to your desktop perhaps, and
Okay.
then you can easily upload that to our website. And then yeah, the next part is just paying for it, and then it gets submitted. Now we actually can't see it in our lineup. We have it set up so that it drops in once it is paid for and that submission's completed, and then it drops into one of our queues.
Okay.
So
And
yeah,
what's the turnaround time to get a report?
it's about a week.
A week. Okay.
So about 5 business days is what we aim for. And then we do have an ASAP option as well. So if you're like, wow, there's a big lesion, I'm really concerned about it, or maybe the patient has a history of cancer or something like that, and they're very concerned. There's an additional fee, but you can do an ASAP, and you'll get that in 1 to 2 days,
Wow. Okay.
sometimes same day. So
Great.
yeah,
Well, it's a great
yeah,
service. I talk about it all the time. Um,
awesome.
so because I know you, I know who you are, and I know what kind of work you do. You're very thorough.
Thank you.
It's not just a general report. You go deep into it, and I've seen it. So um,
Thank you. Yeah, we do. We want to add additional things onto the report. Sometimes you're reading a radiology report and you're like, I have no idea what they said. And so, if we say, oh, there's an anostosis, well, what is an anostosis? Go ahead and put that additional information in. So it makes it really easy for the doctor to just look like a massive hero when he's handing this to the patient. So the patient says, oh, I don't know what that is. And even if you don't know what that is, it's spelled out
yeah,
easily right for you. So
yeah.
it makes it super simple to know what everything is. And then we give some, management options as well, especially if it's a particular lesion. We'll discuss, the features of that lesion and what the patient can expect as far as management for that.
Okay.
Yeah.
What is the best way to contact you if they have any questions about the reports? Is it through your website or is
It
there an
is. We
email?
actually have a feature through the website where you can text back and forth with us within that case submission. So it's all HIPAA compliant. It's all within that patient case. They can text back and forth. So you can actually type in these little boxes that say, comments for the radiologist or that sort of thing. But there's also an email contact through the website, which comes right to me. And on our reports, we'll also go ahead and put down our phone number and our email so
Okay.
that if you didn't want to use the in-website chat service, you could email us directly or call us directly. So for whoever has read the CBCT.
Okay.
So I do work with a group, and I know how everybody was trained. Everybody's from UNC Chapel Hill, and everybody has extensive years of reviewing CBCTs and education. And for instance, my program director from UNC Chapel Hill retired and came to join me, and he is an amazing individual that has done the dosimetry for almost every CBCT that's on the market.
Okay.
And he's still working on that kind of stuff. So yeah, I have a great team that works with me.
That's great. What is the website once again?
It's www.dentalradiologydiagnostics.com. And then, of course, we do have our educational one that I'm super excited about. And that's www.drdxdocs.com.
Great.
So,
well,
yeah.
Thank you for all the information. It was a lot. Very, very informative, so I appreciate it. It's good to see you again.
Thank you for letting me play with the your software, and that's a great case. That's a really fun case.
Fun for you. Awesome. Radiologists.
Okay. Back to the thick and twisted world of a radiologist. Yeah, we always get excited to see these things. I know it's not, we feel bad for the patient, of course.
Sure.
But it's really cool to get to see interesting things. And as a geeky radiologist, it's like, wow, that was so awesome.
Yeah.
But yeah.
I always learn a lot from you, so thanks for your time. I appreciate it.
Well, thank you. I appreciate it. It's so fun to get to see you.
I know. We need to do more things together for sure. So we'll figure it out.
Yeah. And nice, well, I guess it's tea, but
water.
Coffee and CBCT. Water.
Water or tea and CBCT. It works. All right. Well, have a great day. Thank you again.
Thank you. Bye.
Bye.